Hello, I am Lauren Source. Welcome to this update on multisystem inflammatory syndrome in children. Let's first define MISC. It's a rare, severe hyperinflammatory syndrome in kids, usually up to 6 weeks after SARS-CoV-2 infection, that was first reported in the UK in association with COVID-19. It was initially thought to be Kawasaki's disease or a toxic shock-like disease, but it was quickly determined to have some overlap in the clinical symptoms. On May 14th in 2020, the CDC published a health advisory that provided the case definition and requested reporting of suspected cases of MISC. Since that time, the mortality rate is approximately 2%. This slide shows us what the CDC case definition is. And if you follow on the slide, it's any individual less than 21 years who has a fever as defined as greater than 38 degrees for greater than 24 hours or subjective fever lasting greater than or equal to 24 hours, lab incidence of inflammation, which includes this list down here of all of these inflammatory markers, and evidence of clinically severe illness that requires hospitalization with greater than or equal to 2 organs involved, as well as no alternative plausible diagnoses, and either a current SARS-CoV-2 infection by PCR, serology or antigen test, or COVID-19 exposure within 4 weeks prior to the onset of symptoms. Additionally, you should know that some individuals may fulfill full or partial criteria for Kawasaki's disease, but should be reported if they meet the case definition of MISC. The WHO also has a case definition that was published on May 15th, and you'll see it in the next slide how it compares. So on this slide, you can see the criteria all the way to the left, and then the CDC case definition and the WHO case definition. There are some similarities and some minor differences, including age, requirement for fever, multisystem involvement is the same with the exception of hospitalization for the CDC. There's more markers in the CDC case definition. No plausible alternative for CDC, but for the WHO is no obvious microbial cause. And then they both have PCR, serology, or antigen, and then CDC has exposure, but the WHO has likely contact with others. In this CDC graph, you can see a 7-day moving average number of MISC and COVID cases since the onset in February of 2020 through March 21st. These are those that are reported nationally and on this graph as at a monthly interval. The grayed out area here on this side represents the most recent 6 weeks of data for which MISC cases reporting is still incomplete. If we look at the national distribution as put forth by the CDC up to March 29th, you can see where MISC is more heavily concentrated in the darker blue areas. This is consistent with cases of COVID. On this slide, you can see that 34% of the MISC cases are represented by children who are Hispanic Latino, followed by Black non-Hispanic, followed by white non-Hispanic. In terms of biological sex, males are more affected by MISC than females. Looking at this slide, we can see that the age group of 5 to 9 years are the children that have the most incidence of MISC, followed by 10 to 14-year-olds. And as of May 3rd, 2021, there have been 3,742 cases of MISC with 35 deaths. So let's move on to management and treatment. In June 2020, the American College of Rheumatology published clinical guidance for multisystem inflammatory syndrome in children associated with SARS-CoV-2 and hyperinflammation in pediatric COVID. However, this most recent edition, called version 2, was published in 2021. And on this slide, you can see an algorithm for clinicians to follow in order to determine diagnostically and treatment for children who are suspected of having MISC. So the first question that gets asked is, does the child have all of the following, and provides the list of clinical features and findings. On here, you can see that they acquire at least 2 of the suggestive critical criteria. If the answer is yes, and no other causes can be explained, then the child is considered to be under investigation for MISC. If the child has shock of unclear etiology, a complete full diagnostic evaluation, both Tier 1 and Tier 2 for MISC, should be initiated. If they do not, then you start a tiered diagnostic evaluation, and that would be Tier 1 with screening evaluation of these lab values here. If the lab values are consistent with MISC, then a Tier 2 evaluation is initiated. If it is not, then you continue your diagnostic evaluation per standard of care and monitor for MISC. If the patient requires hospitalization for MISC and the patient has shock or organ-threatening disease, then the child starts with IVIG 2 grams per kilo and methylprednisolone 1 to 2 mg per kg per day. If the child has refractory disease, then therapy can be intensified with increasing prednisolone to 10 to 30 milligrams per kilogram per day and or high-dose anakinra. If the child does not have shock or organ-threatening disease, first-line treatment is IVIG, same as if they do, and then if the patient continues to have refractory disease, methylprednisolone is added or high-dose anakinra is added. In response to seeing MISC in the New York area, Columbia University Children's Health and New York Presbyterian Morgan Stanley Children's Hospital developed a clinical inpatient protocol for the evaluation, management, and follow-up of patients with MISC. This protocol was developed by a multidisciplinary team of providers, including cardiology, pharmacy, critical care, dermatology, gastroenterology, hematology, immunology, rheumatology, infectious disease, neurology, and the stem cell transplant team. They put this in place for initiating the treatment for when patients present to the emergency department. As you can see, these are the initial lab testings, which are mostly consistent with the American College of Rheumatology, with SARS-CoV-2 testing, making sure to get serologies before IVIG, as well as CBC, CMP, and indices of inflammation. They also want blood, urine, and throat cultures, UA, and immunoglobulins. Additionally, ECG, echocardiogram, and chest X-ray are ordered. Organ-specific workups are done based on patient symptoms. So patients who present with GI symptoms, if a stool PCR is available for SARS, they recommend getting that, as well as a PCR panel for GI pathogens, calprotectin, C. diff, tox, if they have diarrhea. Their protocol for workup on organ-specific testing based on patient symptoms includes dermatologic with photos of the rash installed to the chart, testing for HSV, varicella, and enterovirus PCRs of any erosion, blister, or varicella-like lesion. For children with neurological symptoms, head imaging should be considered if there's focal neurologic deficit or altered mental status, seizure, or severe headache with or without meningeal signs. CSF should be considered if it's indicated with an opening pressure, cell count, glucose protein, lactate culture, and an infectious meningitis encephalitis PCR panel, as well as autoimmune encephalitis panel if indicated. The case definition should be recorded according to the CDC definition. As one progresses through this protocol, consults should be done including rheumatology, infectious diseases, and cardiology. Different consults should be placed based on patient presentation. In their protocol, they classify clinical severity by mild, moderate, and severe. You can see that the clinical severity definitions are on your slide. Once the patient is identified as mild, moderate, or severe, management continues in that grid. So as you can see, each one of the severity categories includes a little bit different treatment. It is worth noting that this treatment is different than the American College of Rheumatology recommendations. I will also say that after implementation of this protocol, the authors identified that patients received earlier treatment, fewer were admitted to the PICU, and both PICU and hospital length of stay were decreased. Feldstein and colleagues reported on over 1,100 children diagnosed with either COVID-19 or MISC, and they compared clinical characteristics and outcomes of these children and adolescents between March 15th and October 31st of 2020 in 66 hospitals in 31 U.S. states. Their final data follow-up was January 5th, 2021. This manuscript followed their July 2020 New England Journal of Medicine paper describing MISC and the temporal association with COVID-19. By demographics, they compared patients with severe COVID-19 compared to patients with MISC, and those with MISC were more likely to be 6 to 12 years old versus 0 to 5 years old, and non-Hispanic Black compared to white. We can also see that the patients in the MISC group were more likely to receive IVIG, steroids, anticoagulation, and antiplatelet therapy, as well as receive tocilizumab. When we look at this population and severe organ involvement, we can see that patients with severe acute COVID were more likely to have infiltrates on chest radiograph and a lower respiratory infection compared to those with MISC having an asthma exacerbation and pleural effusions. Children with MISC were much more likely to have cardiovascular effects, including pleural effusion, changes in ejection fraction, aneurysm, arrhythmia, and hematologic changes. When we look at severe organ involvement subcategories, we see that children with MISC were more likely to have severe cardiorespiratory involvement, but children with severe COVID had severe respiratory without cardiovascular involvement, and children with MISC were more likely to have severe cardiovascular without respiratory involvement and mucocutaneous involvement without severe cardiorespiratory involvement. However, children with severe COVID had hematologic, neurologic, or GI severe involvement only. When we look at critical care interventions, children with MISC were much more likely to have vasopressor use. In clinical outcomes, children with MISC were more likely to be admitted to the ICU. In 2021, Abrams and colleagues published a paper on factors linked to severe outcomes in multisystem inflammatory syndrome and MISC in kids in the United States using a retrospective surveillance study methodology. They enrolled just over 1,000 patients between March 10th and October 10th of 2020. The primary outcomes are listed there, with those children ages 6 to 12 and 13 to 20 more likely to be admitted to the ICU. Children were more likely, those who were non-Hispanic Black compared to non-Hispanic whites, to be admitted to the ICU, as well as those with shortness of breath, abdominal pain, and increased CRP, troponin, ferritin, D-dimers, BNPs, IL-6, or those with decreased platelets or lymphocytes. They found that coronary abnormalities were more common in males than females, and they discovered that the patient factor of obesity was not associated with a decreased cardiac function. Here you can see a systematic review that was published by Kosick et al. In the Pediatric Infectious Disease Journal in 2020. They performed a systematic review to clarify the clinical spectrum, treatment modalities, and outcomes of MISC. They included studies that had all children up to age 21 with MISC associated with SARS-CoV-2 virus, all study designs and that had an outcome associated with it. Excluded were guidelines, consensus documents, trials reviews, systematic reviews, webinars, or conference proceedings, or other coronavirus infections. On this slide, you can see that many of the studies that were part of the systematic review were done in the United States. However, there were several from India, Spain, Italy, France, and the UK. You can see in the red box just highlighted the clinical symptoms that were associated with MISC associated with SARS-CoV-2. In this table, you can see the geographic variation in presenting symptoms of MISC. Interestingly, in the United States and India, fever was 100% of the time noted in presenting patients, and you can see the variability of the other presenting symptoms in MISC. As far as treatment for MISC is concerned, you can see that the majority received IVIG, with some requiring a second dose for ongoing fever. 49% received corticosteroids, 8% for anakinra, and you can see the remaining treatments below. In terms of critical care therapies, 40% received inotropes, 15% were ventilated, and almost 3% were on ECMO. 34% received anticoagulation, and nearly all reported antibiotics for rule out sepsis. As far as outcomes, 87% were discharged, although 11% were still hospitalized at the time of publication submission. Nearly 2% died, with 6 of those deaths being on ECMO. In a recent publication in JAMA, there was an association of IV immunoglobulins plus steroids versus immunoglobulins alone regarding course of fever with MISC in kids. It was a retrospective cohort study that looked at steroids plus IVIG or IVIG alone, evaluating fever persistence at 2 days or return of the fever within 7 days. 111 children were enrolled, but 5 received neither treatment. In the IVIG alone, there were 37 of 72 cases that were non-responders, and in the IVIG plus steroids, 33 of 34 were non-responders. In terms of outcomes, children who received IVIG plus steroids had associated lower rate of treatment failure, decreased second-line therapies, less acute left ventricular dysfunction, less hemodynamic support, and shorter PICU length of stay. So in summary, for this update on MISC, the information that we have on this disease continues to evolve. Investigations into a variety of treatment or supportive care domains are ongoing, and long-term follow-up will elucidate the impact of MISC on children. Thank you for your kind attention.